watching this, you may be interested in genetic screening for cancer susceptibility. Maybe you have a strong history of breast cancer in your family and wonder if BRCA screening is right for you. Or maybe you're thinking about having your whole genome sequenced, possibly to reveal something about your future health status. With these decisions arise many questions. I hope I can answer some of those questions and maybe even pose a few new questions to ponder as you consider your decision in genetic screening. I'm Brittany Avon, and we will discuss the large and small scale of screening, the science behind it, and the pros and cons of screening, so you can critically move forward. While I have already mentioned a few reasons why one would want to have genetic screening, what are the main factors that would influence a healthcare professional to recommend screening? Many people have genetic screening for cancer risk assessment suggested if they have personally or through family history had relations to cancer that show signs of being hereditary in nature. Some such signs or features that may be a sign of hereditary cancer that would warrant genetic screening are very early onset of the disease, more than one type of cancer in the same one person, the same type of cancer in multiple close relatives, and/or cancer happening in multiple generations of your family, rare or uncommon cancers or tumor histology, or being part of an ethnic population with strong risk, such as the Ashkenazi Jews and a high penetrance of BRCA mutations. Genetic testing can also be conducted once the individual is already diagnosed to have better cancer management or personalized medicine. However, we will focus today mainly on patients before treatment. Broadly, what does it mean to have genetic screening, and what are the options? When someone conducts a genetic test, they are looking for specific mutations and inherited change in a person's genetic material, their DNA. Inherited mutations are estimated to play a role in 5 to 10% of cancer cases. Note that this means that most cancer cases are not inherited, but rather are spontaneous, of no inherited genetic cause. But even if one does inherit the mutation, they may not get cancer. See here a man and a woman of which their offspring inherits one of their chromosomes for each chromosome pair. Note that if the father has a mutation in a part of his DNA, that the son may also get that same mutation. Everyone inherits 2 copies of each gene, so that if one inherits one mutated and one normal gene, they will function fine unless environmentally or by chance the other normal gene becomes mutated. In this specific example, if this happens, it can cause an increased risk in development of cancer in a variety of ways. Again, looking at this man's pair of chromosomes that are both mutated. The genes and the DNA make up the chromosome. Let's say that a particular gene on this chromosome controls proliferation or cell growth. And normally, you get normal cell growth. However, if this person does have a mutation in this gene, which may mean that this DNA base T is mutated to a G, that this causes a change in the protein that's expressed from the gene so that there's higher levels of proliferation. It's mutated to not function properly, and then cell growth can increase, which can lead to cancer. However, this is very simplified because tumors are comprised of many different types of mutations, not one single mutation. One single mutation is not enough to cause cancerous growth. When cells comprising a tumor were sequenced, it was found that 1/3 of the mutations were the same in the entire tumor. That means that 2/3 of the mutations within a single tumor were different. Just an example of the heterogeneity that exists within cancer. Mutations within the tumor differ, and it is not a single mutation that can cause malignancy, but multiple mutations in the cellular environment. So if one is considering genetic screening to test for these possible mutations, there are two main options. One, being whole genome sequencing or other wide-covering sequencing, which is gaining favor recently as technology improves. Or two, smaller scale screening, testing for only single genes with known mutations that correlate with cancer. To understand these two avenues, let's look at an analogy for a book. The book represents the entire genome. All of the DNA material that a person has is in this one book. Within the book, there are many pages, all with more written material on them. If we look at one page, let's say that one page represents a gene. Now, the entire book is the genome, which is comprised of many, many different genes that all have different functions. But let's say on this page with the gene, there's a single sentence, "The fat cat sings." But if this single sentence within the gene is mutated, or it has a variation, maybe we get "The fat rat sings," a different connotation, and possibly could change the entire meaning of the page, which could have an effect on the entire book. When we're doing sequencing, we can look on the sentence level, looking at a particular variant in a specific gene, like BRCA testing for breast cancer. Or now we can also look on the entire genome level on the book, sequencing all of the words, all of the sentences, all of the pages, and the entire human genome. Once it is decided what sequencing technique is desired, the process is seen here. For testing that takes place under clinical supervision, a person will have blood drawn or other fluid that contains their genetic information or DNA. Their DNA will be sequenced for either a specific gene, which is known as targeted sequence capture, or all the genes that make up just the proteins in a person, called whole exome sequencing, or all the DNA in its entirety, whole genome sequencing. Sequences are done by DNA sequencers that read the DNA, with each read made a small part of your entire sequence, so that all the reads in the end are added together. And this is done by having a reference sequence to match your reads to with the known sequence, which is the human genome sequence. The sequences will then be analyzed to look for variants or changes in the DNA. Of the results from a test, which usually take about a month to get back, one can have a result, which means that they found a specific gene that was mutated that's known to correlate with a certain cancer risk. Result. And this means that there's no specific alteration in the gene that was tested. This negative, however, does not mean that the patient cannot get that type of cancer, but rather that their risk is the same as the general population's risk for the cancer. And lastly, also possibly get an uninformative result. And this means that there was an inconclusive answer in the ability to sequence that particular variant, or possibly that the patient exhibited an unknown variant, or a variant that was shown to not be necessarily linked to anything or to predispose someone, which is also known as an unknown polymorphism. Before we continue, let's make sure we understand the difference between correlation and causation. I know I've used it a couple times, but let's make sure we understand, as this will be very important as we move forward. To understand the difference between correlation and causation, let's look at an example. As seen by this hilarious example, the age of Miss America strongly correlates with murders by hot things. This is a correlation. In no way does the age of Miss America dictate how many people will be killed by steam in that year. So when we start talking about genes implicated in certain types of cancer, we have to keep in mind that while a mutated gene has been shown to be correlated with the disease or a certain variant, having this mutated gene does not mean that one will have the disease. Correlation means that there's a relationship between two items, while a cause is when something occurs as a result of another thing. Say that someone has a mutation, such as a BRCA mutation or a variant for colon cancer, and that it's correlated with breast cancer or colon cancer. Just because they have the mutation does not in any way mean that 100% they will have cancer. It means that they have an increased risk. One must keep in mind that cancer is a multifactorial disease, meaning that it usually does not have one root cause, but is a product of genetic, environmental, medical, and lifestyle choices, all factoring together. While understanding the genetic component of the disease can shed light on at-risk individuals or help individualize treatment options, genetic screening must be properly understood to be beneficial. Genetic screening can help identify certain mutations that have been previously implicated in correlating with an increased risk of inheriting this disease. This risk can vary, and penetrance is a good way to understand the risk. Penetrance is the proportion of people that have a mutation that will end up having the disease. The common genetic variants or mutations that many people have in the population have low penetrance, meaning that the amount of people that have those mutations that end up actually having the disease is low. While rare variants, like BRCA mutations, that are not as common have higher penetrance, with many people getting the disease, and thus the increased risk that comes along with having a BRCA mutation. Keep in mind that a variant may not increase your risk all that much if it has low penetrance. So when receiving information on different mutations or variants, take into account the penetrance of that variant to understand your relative risk. Let's look into an example with BRCA mutations. For the BRCA1 and 2 mutations, BRCA1 and 2 increase the risk of female ovarian and breast cancer. These mutations account for 20 to 25% of hereditary breast cancer, meaning that these mutations do not even account for all familial breast cancer. 3/4 of breast cancer that is done through hereditary inheritance is not because of these mutations. And only 5 to 10% of all breast cancers are due to BRCA mutations. When we consider the general population, overall, 12% of women will develop breast cancer at some point in their lifetime. With a mutation in BRCA1 or BRCA2, this likelihood increases to around 60% of women with the BRCA1 mutation will have breast cancer by age 70. With these facts, some women do elect to have genetic screening to understand the risk of breast and ovarian cancer personally. While what has been discussed so far refers to genetic testing overseen by a healthcare professional, we would like to touch briefly on the recent pop-up of direct-to-consumer genetic testing, such as through the company 23andMe. These are not through the guidance of your doctor, and this screening usually results in a wide variety of results. Testing through your doctor is normally for pinpointed superhereditary conditions, while at-home screening looks for numerous inherited genetic variants, including ones that could be correlated with cancer through single nucleotide polymorphisms, or SNPs. These SNPs are single base changes in DNA that have been shown through statistical analysis to be associated with a certain type of cancer. The variant by itself usually only increases risk of cancer very minimally, so that all the known variants together only influence one's cancer risk by a very small percentage. These variants have not yet been shown to help patient care, so are not clinically recommended. Basing too much of your health decision on these types of screening and tests can give incomplete information that can only cause anxiety. So really think about what you're doing with this testing. And speaking to the pros and cons of at-home screening, what are the larger implications of genetic screening as a whole? But let's now speak to some of the positives of genetic screening for cancer risk. Being tested and finding out you do have a mutation that increases your risk of developing a certain cancer can help with life-saving management, interventions, and closer monitoring. One may have more vigilance with yearly mammograms or colonoscopies after knowing that they have a mutation that predisposes them to cancer. This overall makes the population more knowledgeable about cancer risk and helps one lead a healthier lifestyle. However, while this is all very positive, the increase in people's use of screening or other diagnostic testing and treatments due to people's reaction to genetic testing could overwhelm the healthcare system, including doctors and patients. Sequencing is continuing to decline in cost, making it more affordable and attainable for the general population. Sequencing would be the beginning of a long road of screening and diagnostic tests to understand if the patient has an illness that their genome might suggest, which would increase healthcare costs for additional extra tests that may be unwarranted but simply be completed because the patient is concerned. Another possible risk many see to genetic testing is discrimination by others based on your genetic test results. Congress did enact the Genetic Information Non-Discrimination Act, or GINA, in 2008 to protect people from genetic discrimination, which added to the protections many states already had in place. This law laid the groundwork to make it illegal for you to be treated differently by your employer or health insurance because of a genetic mutation. Remember, though, that while it can protect from discrimination, GINA does not prevent long-term care, disability, or life insurance providers from using genetic test results to make decisions about your coverage, and mutation status could affect these choices. Another potential con to genetic screening is the emotional and mental aspects of screening. As a mutation does not necessarily mean you will get the cancer, but you may have an increased risk, this can cause much stress and a sense of waiting for bad to happen. Some people may feel that they would rather not know if they're going to have cancer in the future and simply deal with the disease if the issue arises later, than wait expectantly for years, worried about possibly having the disease. Testing can also cause tension within families, as sometimes testing, like BRCA testing for example, needs to be done on close family members as well as the patient for accuracy. And trouble can arise if some family members have differing opinions about knowing. Or a positive result in one family member may trigger anxiety in other family members, and then a burden of cost for testing can follow for other members of the family to find out if they too carry the mutation. Lastly, testing can also impact personal choices and family planning. One may choose to have preventative surgery, such as double mastectomies, or some may go to the extreme of choosing to not have children for fear of passing on a mutation. All of these factors must be taken into consideration when considering screening. We will continue to see a rise in genetic screening as testing becomes more and more in the vocabulary of clinicians and the general population. Science has made leaps and bounds in large-scale efforts for genome sequencing. To sequence the first genome, it took $2.7 billion and over 10 years. Now, it can take less than a day and can be done for under $5,000. Many think that this is the new health wave of the future, seeing as Myriad Genetics, the company that had the patent on BRCA genes for testing, charged $3,000, which is over half of the $5,000 now, just for testing for 2 single genes mutations. So now, for $5,000, the entire genome can be sequenced, versus $3,000 for 2 single genes. Research is finding all of the time new genes to be linked to cancers that through screening can be used to reduce cancer deaths, as shown by a study at the Institute of Cancer Research in London, published this January on patients with a family history of bowel cancer. A group of genes responsible for repairing mismatches and base pairing in DNA was found to be mutated in 11% of the cancer cases tested, with other genes known to have a total of a quarter of the genetic causes for the disease possibly known. This can help in screening and identifying at-risk patients to start treatment earlier to prevent death from bowel cancer. However, 3/4 of bowel cancers still have no genetic link, so science is continuing. But this is just one example of how known genetic mutations that are being found can be helping patients using screening for earlier detection. An ongoing effort occurring right now is taking place through the Cancer Genetic Markers of Susceptibility, or CGEMS project. This project looks for inherited genetic variants that correlate with a risk for different types of cancer. This happens through genome-wide association studies, looking at the entire genome and looking at different variants within, from the National Cancer Institute Cohort Consortium on the large-scale scanning for variants. Once this happens, this will offer so much important information on variants that can be used for screening. I'll leave you with this. Genetic screening has come a far way, but still, we have a very far way to go. This, I think, really illustrates the point of taking genetic screening to help your inform decisions, but to take with a grain of salt. A study published in the Journal of American Medical Association from Stanford University said that, at present, right now, whole genome sequencing conducted on a dozen volunteers didn't stack up. The screening did not completely cover the known disease genes, so that 1 in 5 known disease genes were missed. The screening inconsistently found the riskiest of known variants, only 1/3 of the time finding them. And the screening could not conclusively define anything on the patient's health status. In the study, the sequencing and the follow-up costed $16,000 per patient. On average, there were about 100 variants per patient, of which to understand each variant and its potential impact, it took an hour per variant, or 100 hours per patient. And these were some of the variants that they had no idea what they would correlate to disease-wise. It shows how far we have to go in using genetic screening as an end-all be-all. One of my quotes that I think really sums up the issue here, and which I'll leave you on, is from a genetic counselor. It says, "Genotype will not always predict phenotype, for DNA is not destiny." Remember this as you go through genetic screening. Wonderful resources can be found if you're still interested in looking at all the different aspects that encompass genetic screening. For example, My Cancer Genome is a genetically informed cancer medicine website. You can search a type of cancer and common mutations that are associated with that cancer or specific variants. Even clinical trials associated with these variants can be found, along with education on the specific genetic consequences. The National Cancer Institute, as well as the American Cancer Society, also have information for the general public on genetic screening for cancer susceptibility. We hope that you will take use of these resources